Slide. So we're hosting this session on the unceded and ancestral territories of the Coast Salish peoples. That includes the territories of the Musqueam, Musqueam, Tsleil-Waututh nations, as well as the Métis Charter community of the Lower Mainland region. And all of you around this province and other places are coming from your lands and recognizing our promise to truth and reconciliation, as well as learning and understanding the land and the peoples and respecting both so that we can improve the lots of all. So just reflections on this Friday morning, knowing that the weather theoretically is going to change and we're going to have to live within those limitations. Next slide. So province-wide rounds is a collaboration between UBC Division of Nephrology and BC Renal. We're very grateful to all of our funding partners, as well as all of our health authorities. They're all listed on this slide. And uniquely today, next slide, we're going to have HARP presentations for you. So those of you that don't know what HARP stands for, it's Health Authority Renal Program. And importantly, these are opportunities for us to learn from each other about best practices, novel ideas, innovations, and things like that. So Scott Hobson is the clinical operations manager for the renal program at Vancouver General. He's proudly born and raised in Powell River on the Sunshine Coast, north of Seashelt and Gibsons. He has a background as a registered nurse, working on mostly before renal on acute med surg floors, and is a proud uncle of 5 nieces and nephews, with 3 of them being of which 3 are triplets. That's not so that everyone can say. And Monique Leblanc has been a registered nurse since 2009, worked in PD, peritoneal dialysis at the Abbotsford Regional Hospital unit since 2014. She became a certified diabetes educator in 2022 and has lived herself with type 1 diabetes since 1996. She began working on projects to improve diabetes management in PD after noticing how little there was about this, and wanted to really make a difference. So these projects include, I think we're going to hear a lot about them, so I don't want to steal any of your thunder, but her goal is to get diabetes educators employed within renal programs to meet the unique needs of these patients who have both kidney failure and are on dialysis. So without much ado, I'm going to hand it over. We're going to have 2 sessions. I believe Monique is going first, then there's a Q&A, and then Scott, or maybe the other way around, but however it goes, we can start now. So thanks very much for the 2 of you, not just for your presentation, but the work that you do, because these are presentations about a series of activities that are all designed to improve care. So over to you.
Yeah, I think it is myself that will be going first. So I will share my screen here. All right, everyone can see. Thumbs up. Perfect. All right, well, thank you very much for starting that off in a good way, Dr. Levin, and yes, welcome everybody. As mentioned, my name is Scott Hobson. I am the manager of the VGH renal program here. I've been managing this program for just over a year. So still, I would say, somewhat fairly new to the renal world, but nonetheless, very excited and happy to be presenting for today. So one of the projects that we have been working on for the last couple of months is our home dialysis referral pathway with a focus on our PD screening. So just for today, some of our learning objectives is just to identify key roles and responsibilities of the multidisciplinary team members in the referral pathway, explain the importance of early and systematic screening for PD candidacy, describe the components of the home dialysis referral pathway and impacts to various renal departments, and really just understand our common barriers to PD referral and uptake. So just the background and rationale to this. So we've had an increased demand on in-center HD, and I know that this is fairly common throughout the province, and really just trying to align with the strategic direction to increase home modality uptake, and really just having this as a focus on sort of our PD. So just looking back at some of our statistics from July of 2024, you can see that we've had a fairly consistent number of new patients with really just one spike up in March. And it's roughly around 3 patients, new starts per month. When we compared that to the provincial average, that is around, similar numbers when you do the percentage. But still, I think there is an opportunity for us for a need for consistent referral, screening, and tracking processes. When we did look at it, we did see that there's a variability in current practices across our KCC and HD programs in terms of getting our PD referrals. And really, we have a goal of streamlining those referrals, improving our PD uptake, and really just enhancing that patient-centered care and having that knowledge and education as far in advance as possible, knowing that we have different streams of patients that are coming into our renal program. So really this came about, and I think this was some really great work that was done with a project from BC Renal about the home dialysis referral pathway. A lot of this work started in our HD program with a real focus on how can we get our patients from HD to our home modalities. We did some of that work, but once we started this work, we really realized that there was a lot of gaps within our program that isn't straight just from our HD program. We realized that from KCC, we also had some needs here to actually improve our referral pathway. So this was sort of the catalyst to this project and to really do a bit of a deeper dive in our work. So this is some of our data that we had pulled, and this is thanks to our data coordinator, Arjun. And really, it's just showcasing our sort of average length of stay and our patients that are being referred from KCC over to PD. I will say a caveat of it, this goes back to early 2023, and that length of stay is quite low, and that's mainly because we started our EMR Cerner late 2022. So those numbers are a bit skewed on the lower end for the average length of stay, but the numbers for actual new patients are accurate. So fairly average between, like we said, from the original, around 2 to 3. And then when we go over to our HD program, you can see the numbers are significantly less. We do have about 1 to 2 patients that go from HD to PD. So really just trying to understand the root cause of this. Is there opportunity there to identify, screen, and refer from these programs? So just our current state in KCC, doing an environmental scan. The kidney clinic does have a referral form. It does identify the modality medical contraindications. It does speak to the suitability for group education and the estimated progress to KRTs. When we looked at it a bit further, there is a non-uniform approach to the KRT modality education. So this is something that we want to focus on from our KCC staff to have a bit more of a uniformed modality education for each patient as much as possible. This does occur every 2 months with our social work and RN. And one of the interesting things that we did find out is that the education focuses on the modality that the MD thinks is best for the patient and was never really necessarily reconsidered once we did an initial assessment with the patient. So on referral, if the MD said that they're HD, we did not do any modality education for the home modalities. So interesting point to look into. We do have our choices class that is 6 times per year. There is no specific home hemo or PD separate education class. So another option for us is looking forward to actually adding those in, which is something that our PD educator and our KCC educator are looking at implementing into the new year. Another point is that access to these classes is really all in person. There's no virtual or recorded option. And it's limited to our small conference room that can only manage about 3 to 4 patients plus a family member. So we can only have a small amount of patients that actually are able to come. So does that limit us going forward? For the scan in HD, we do have our patients as they come into our HD, whether they're sort of our crash patients or they're coming from KCC, the RNs do have a checklist to ask if patient has discussed home therapies with them. We do have our HD rounds that happen Q weekly, just to discuss new patient starts within the 6 weeks. However, we don't have an established interval to reassess or rescreen patients after that 6-week rounds that occurs. So there's variable documentation in our EMR to state there's contraindications or reasons for that chosen modality or potential patient refusal. And our patient navigator is responsible for discussing the home modality suitability with the patient, and information is provided PRN. However, again, this is intermittent. Our patients transitioning from KCC do not include details regarding our modality education received, which is really a large gap in our communication between the units. So it's emailed to the primary nephrologist, allied health team, and PCC, but this is not recorded in the EMR. So transitions of care could be compromised. Patient does receive a welcome letter that is given to the patients that states home modalities may be discussed, but there is also no further group education or any sort of individualized education around home modalities in our HD program, which could lead to an opportunity. So summarizing some of the identified gaps and barriers, it's fragmented communication between our KCC and HD. There's a lack of standardized EMR documentation, some limited patient education opportunities and capacity. There's a minimal rescreening for PD suitability. And there's a bit of role ambiguity across our care teams and low visibility of home therapies and patient education. So some of our learnings to date, just need for consistent PD screening at defined intervals. There's a large importance of shared EMR documentation for modality discussions, which we are able to leverage sort of our informatics team to help support with this. Focusing on early introduction of home dialysis options will and hopefully will improve uptake. And really focusing on that patient-centered education, so choice, accessibility, and format is key. And really having that interdisciplinary collaboration to improve follow-through. So our proposed future state that we have for the program is really having that early identification, having that MD, RN complete standardized PD screening at first referral, whether that be in KCC once we are seeing that patient on the first referral, or if they are coming to HD, whether they've been seen through KCC or not, having those done. Really establishing an ongoing review, so reassessing PD suitability every 3 to 6 months and documenting the decisions. Education and engagement, so developing our modular PD home hemo-specific education, both virtual and in person. And having that transition to HD, so ensuring modality education summaries included in a transfer note and documented appropriately in the EMR. Some of the roles and responsibilities that are important to this process, so our nephrologists, of course, are early referral and reviewing the candidacy and documenting those decisions. Our RNs, both in the KCC and HD, completing those PD screening checklists and having that patient follow-up, so that it's really intentional. Our social worker really helping with assessing the psychosocial readiness and support that patient decision, and really working through with them, whether they're having some barriers or concerns about the choices. Our navigator really helping with tracking the education, documentation, and follow-up for our patients. Our educators helping facilitate those PD and home hemo sessions. And then our data quality coordinator monitoring the referral metrics and PD uptake. And then myself as the unit manager, really establishing those attainable goals, project timeline, and reviewing at regular intervals. So then next steps is finalizing our standardized PD screening tool. So we have not actually developed it as of this presentation, but that is something that we will be doing. Building an EMR documentation template, developing our PD specific education module, both virtual and in person. having the data coordinator pilot a referral tracking dashboard, which is in progress, and implementing our quarterly rescreening for PD suitability. And then the last piece is our accountability and measurement. So really just tracking our percentage of KCC and HD referrals with documented PD screening. So although it's great that we have our numbers of new starts, it's really understanding, can we track the amount of referrals? Are we actually making sure that we have as many patients as possible screened? Continue to monitor our PD uptake through the BC Renal Indicator Report, having audits of our EMR completion for the modality education, and then implementing and reviewing some patient feedback surveys as well. And that's the last bit of my presentation, so I'll just open it up for any questions or feedback.
Yeah, thank you, Scott, and thanks for presenting that. Yeah, I'm looking if there are some questions that people want to ask in the Q&A or else put up their hand, but I thought there were some standardized assessment tools for suitability for home and PD, but maybe I'm wrong about that. But it's a great initiative, and certainly corralling all of the existing resources and standardizing has always been shown to be a good way to change behavior and outcomes. So that's great, and I thank you for the presentation involving all the people that you have. Just wanting others to ask questions. I'm scrolling all the different people to see if I can pick on someone. In terms of patient engagement in some of these design of some of these activities, have you done that as well, or is?
Yeah, that's something that we're looking at doing as we design sort of the process and having the feedback as well, is having that patient involvement. We have done side projects that sort of have some branching elements to this project. We've done a patient stories project, and a lot of it is around a bit of advanced care planning, but also looping in around the transitions of care. So some of that work has been ongoing and it's kind of separate from this, but it kind of loops into this work.
Great, great. Excellent. So I think if there aren't a lot of other questions for now, I think I can say, Scott, like if people do want to understand better or talk to you, that they're free to contact you, right?
Yes.
And I think in the home dialysis assessment section, I think there are some existing assessment tools. So it'd be great to get your feedback on the use of those.
Yeah, yeah, for
Great.
sure. We have seen those for sure. And I think one of the things that we've realized is we have not been using a lot of those tools. And that's sort of some of the areas of improvement for us for sure.
Yeah, because I think one of the really great things about working collaboratively in the different health authorities and in the provincial committees is to share and look at existing tools that are out there so that you don't have to do that work, so to speak, right? So the work is in implementing, not developing. So that's great. Monique, you have your hand up.
I was just wondering, when you have your KCC patients or HD patients that are identified as possible PD candidates, do they ever go to the PD unit to meet with the PD nurses for that orientation? Like that's what we do in Fraser. So then like myself, who trains PD patients all the time, we can sometimes work out details that maybe weren't identified from the other sites. Is that something your program does?
I would say yes, but not consistently. So obviously we do have our PD sort of referral process where they officially go and meet the whole team. But in terms of just kind of bringing them and stopping by and having conversations and things like that, that's not necessarily always happening to kind of break some of those barriers or bringing some of the PD staff over to kind of discuss as those subject matter experts. Not as consistent as well.
Okay. We kind of consider them not, PD isn't their choice until they've met with the PD staff over here, which I found has really been quite helpful, because then at least you kind of get the big picture from the PD trained staff. That seems to be really helpful, because then they can walk away knowing the full picture. It's been, yeah, so.
Yeah, no, that's great to hear. And I think I would open up if there's other programs that have found things that have worked really well and made things consistent in their approach. I would be very happy to hear outside of this meeting as well. Please feel free.
Well, Joanna's got her hand up.
Morning, I'm Joanna. I'm the social worker in the PD program at VGH. And I just wanted to add one thing that we found really helpful over the years is patients leaning towards PD modality, and then the social workers trying to connect peer support for that individual, and just patients learning from patients. We found that to be extremely effective, and as well as linking them in with the Kidney Foundation Wellness Hub for support as well. So just wanted to add that.
Thank you.
You're welcome.
Thanks, Joanna.
Okay, well, that's great. Thank you very much for describing that. And I think for all the other programs and program managers, I think, again, one of the reasons for having provincial committees is that people can talk to each other across the things and see what worked. And Monique and others have given some good examples. So that's terrific. Thank you. All right, and thank you on behalf of the province for presenting at our first HARP province-wide round, HARP project province-wide rounds. So at this point, I'm very much on time. I'm going to hand it over to Monique. Over to you.
All right. Hang on a sec here. Okay, so my project last year was how to manage diabetes on peritoneal dialysis. This is not the first project. It has been a series, which I'll explain here briefly in a minute. But as stated in my introduction, there is a lack of knowledge on how to manage diabetes once someone actually starts on dialysis. Like everything's about, all the focus is on preventing kidney failure, but what happens when their kidneys have failed and now they're on dialysis? So that's the gap I'm trying to bridge here. So in the past, we tried having an endocrinologist come to the PD unit. That didn't really meet the needs. Parking was an issue for patients. He didn't have samples here, limited availability and time and space. And then patients were having to come back for a separate appointment, and we couldn't mix it with our PD clinics because not everyone in that clinic needed to actually be seen. So that one kind of crashed and burned very quickly. We next tried educating PD staff to have champions on site. So some staff at each site in Fraser took a course, and unfortunately, a 3-day course is not enough to make someone an expert on diabetes. It is very involved. So the comfort level was not there. Plus we had staff turnover. So people did not feel that comfortable or left, and then we were left without anyone. So that wasn't really the best case. So the next one we worked on was me as a diabetes educator. I had funding for approximately 2 days a month to work on diabetes management. So I focused on people who were having issues with UF, blood sugars, various problems. But even within the first 6 months, it was very apparent that having that one-on-one care with someone focused on their diabetes, not the whole picture, not just the dialysis or other things, we were able to improve UF. We showed improved blood sugars, A1Cs. We were able to use lower strength Dianeal, which again improved blood sugars. We saw weight loss. So there was an incredible improvement. The biggest issue, though, was patients weren't always available when I was available. And if I was working on a role, I'm still full-time PDRN, so I would get pulled away, so I couldn't complete certain things. Patients needed seen sooner. They had some issue going on. Maybe they'd switched from CAPD to APD or were hybrid, and they needed more urgent involvement, but I was on vacation or away, or there just wasn't the resources available. So it really needed to be a regular role, not just sort of a couple days here and there. So what that led to is the following year, so last year, we applied for funding for to continue development of this clinic located within PD at this point, develop educational materials for patients and renal staff to better manage diabetes, control for sick days, transitions between CAPD, CCPD, hybrid, and coordinate education for renal staff to improve patient suitability in PD for PD in the future, which is what shifted me to do more creating what would be sustainable. So knowing the funding would come to an end and we still did not have a diabetes educator role anywhere. So was like, okay, what can we do when this funding ends? So I ended up creating 3 documents, and the first one being starting continuous ambulatory PD, changing from CAPD to APD, and hybrid, because these were 3 critical transition points where things change quite dramatically. So what we are telling them at the beginning changes very dramatically for some at those points. And then I also focused on doing some presentations explaining this. I have already explained to the BC PD nurses these forms, so some of you may have seen this already, but I want to say as of yesterday afternoon, these forms are now available on the Fraser Health patient education catalog. So they are up and running, and I'm told they are accessible to all. So this here is page 1. It might be hard to see, but you can look at the documents later. This is page 1 of the starting continuous ambulatory PD. So brief explanation starts off with explaining why we care. So that they're explaining that people are going to be exposed. Now keep in mind, these are patient handouts, so they have gone through our professional practice team, and everything's written at approximately a grade 6 level for all of this. Explaining that the sugars can affect their blood, or the sugars in the dialysate can affect blood sugars, and we explain why that matters. So this graph here is showing, hey, you've got high blood sugars, they're potentially getting lower UF, which leads to fluid overload. Then they pick a stronger dialysate because that's what we're instructing them to do. And that raises their blood sugars even further, and they get caught in this loop. So until we actually intervene and deal with the blood sugars and the hyperglycemia, we are going to struggle to get a proper UF. And we have seen this several times, especially with type 1s who've come to us with poorly controlled diabetes. Before they came, A1Cs 12, 14 ongoing. Unless we can get the sugars under control, we've seen where they have had to go to hemodialysis because we couldn't maintain them. Other cases, we've been able to intervene, get their blood sugars under control, and things are working great now. So it is a major factor that is not really looked at as in depth as it probably should in a lot of cases. So next part goes into when to check blood sugars. So in the beginning, we said 3 to 7 days, because sometimes you know very quickly how things are going, and others, you need more time. There's more variability. So we want blood sugars ideally 4 times a day. So in the morning, when they wake up, or before breakfast, if that's quite a bit later than when they wake up, before lunch, before dinner, before bed. And that is intended to help figure out how to adjust medications or add medications, etc. So ideally, they're reporting that to you. So checking blood sugar is just a little blurb on needing to possibly have a glucometer, how to secure one, who to talk to if you don't know how to get one. So this is page 2 here. and this goes over if someone's not using a glucometer, but we're seeing more and more CGMs like Dexcom and Libre. Thankfully, they're fantastic. They are not approved currently for dialysis patients, but the initial data that research is showing that it isn't swayed too terribly. Most of the time, it's fairly accurate. So, and even actually, I've been reading over the ISPD cardiovascular and metabolic guidelines that are coming out soon, and they're suggesting the use of CGMs as adjunct to hemoglobin A1Cs. So that is the way things are moving. They are really valuable information because you're getting interstitial blood sugar. So that's where the variability comes in, but you're getting a reading every 5 minutes as opposed to one blood sugar whenever they happen to poke their finger. So this is making a huge difference in how to manage. So we're now able to look at these and see, oh, okay, wow, every time you hook up to your cycler within an hour, your blood sugar is shooting up. And no wonder we're not getting any UFs. Your blood sugar's shooting up to 20 in the night, but every time you check it during the day, it's 10. So it's been pretty eye-opening to see the data from these CGMs. So this breaks down things for them to be considering when they should check their blood sugar with a glucometer, like if they feel unwell, because the sensors can fail. So their backup should always be to poke their finger. Medications. So we just a brief overview that maybe your medications will change now that you're starting on PD because of the solutions that may drive up the blood sugars. Next, I put in a section about injections because we have had a case where we suspected that a PD catheter was punctured because they did an injection over top of the tunnel. So good note to bring up is try whenever you get someone with a new PD catheter, being very diligent about letting them know where they can and can't inject now that there's a tube under the skin. Next, there's discussing solution changes, how your blood sugars might be fine because you're using Dianeal 1.5% primarily, and then all of a sudden you're needing 2.5%. That may change how things work for you, how your blood sugars respond, and that also may mean that your medications may need to change, especially for someone on insulin. Touch briefly on low blood sugars and recommending dextrose tablets or rocket candies versus juice, because as you know, a lot of our patients have fluid restrictions, potassium restrictions. So we've had cases where patients were having high potassium constantly, and we realized he was having multiple lows and using juice constantly to treat them, sometimes more than once a day. So we dealt with his hypoglycemia issues, got him using different treatment and for his hypoglycemia, and his potassium stopped going so high. So again, another factor to consider. Last bit on there, through in the sick day management, there is a link that goes directly to the BC Renal sick day management. And that one I'm also working on adapting. So it includes more specific to dialysis, because the way it's written now is very pre-dialysis focused. There isn't a lot of conversation about fluid adjustments or whatnot. So I have a version of that I'm working on. So the second document here is the how to, when you're switching from CAPD to automated peritoneal dialysis, APD. So everything we've now said for CAPD sometimes changes. So we may have increased in insulin or medications during the day to account for the Dianeal during the day. Well, now the Dianeal is going in at night, and you're starting to see the blood sugars go up at night. So when someone's on a cycler, we also have an endocrinologist in town who's been really mindful of this and has even got people on like a third insulin for an HS insulin or an evening insulin to counteract the glucose from the cycler. So that is definitely a major factor that we couldn't we knew about, but we couldn't really prove, short of having them wake up and check their blood sugars in the middle of the night. So the CGMs are really giving us a lot of data there. So again, goes into repeat of the CGM. So the intention of this form would be to hand it out when and go over it when they're switching to cycler. So a lot of this is repetitive. When to check your blood sugars, we added in during the night while the cycler is running if they are not on a CGM. So if once in a while they're able to wake up a few hours after the cycler begins to find out what their sugars are, that is really helpful data. But of course, CGM would be even better if they can afford it, or if they qualify for it, because there are restrictions for that in terms of special authority. If the cycler is not working, then this is telling them to refer back to the initial starting CAPD guide if they can't get the machine working, especially after a couple of days. They should be reaching out to their PD unit, because all those changes to medications that were made for the cycler, now they're not on cycler. I've had people where their blood sugars are great when they're on cycler, something happens, they don't use a cycler that night, and by morning they're having a low blood sugar. So these are things that they need to be aware of. Not that everyone's going to be the expert on how to manage that, but they should, or like as the staff, but it is something that we should make sure patients are aware of that can happen, and to know to reach out. So the third document here is if you're on HD and PD, and this gets very complicated. So tried to break it down as best I can, but there's so many variables to this. But if you've got someone who's doing PD one day and then no PD the next and doing HD, that is going to fluctuate things. I've had a hybrid patient recently. He went to hemodialysis, and the day he was running hemo, he would check his blood sugars at the beginning, mid, and end of run. And from the start of his run to the end of his run, he would drop 4 points. So, if he was doing insulin for all his dianeal fluids, so he was getting lows. So we had to start looking at a regime for, okay, what do you do on HD days versus PD days? So it gets kind of messy especially when they're on insulin. So again, starting out with an explanation of why this matters. So when doing HD, noted that people can get low during the run from changes to your PD routine, changes to meal times or the amount you eat, because as you know, hemo, sometimes they aren't allowed to eat depending on the person during their runs. They might be, it's in the middle of their meal time, so they're skipping meals, but still doing their medications the same way. Activity levels change. Maybe they're usually active at that time. Now they're sitting in a bed for 4 hours. Maybe they're taking more insulin than needed, as they said. So times to watch for low blood sugars is during and after an HD run, during the night, and first thing in the morning if not using a cycler when they normally are, or anytime PD is put on hold. So if they end up holding PD for a week or whatnot, that's going to vary things as well. And again, a note considering that if you are restricting fluids or potassium, consider using Dex tabs or rocket candies to lower, or for instead of juice. So things you can do for hybrid, these are recommendations here. I'll just read these out here quickly. So trying to eat meals at the same time of day, try to avoid the variability, checking blood sugars more often until they're aware of the changes. So on an HD versus a PD day, checking blood sugars before the HD run, halfway through, and before leaving the HD unit, because I've also seen people where they've left HD and had lows as they're leaving in the lobby or on the way out or in the car, which is scary. If they're using CGMs or flash monitors, making sure they're checking it frequently, and they should have a backup glucometer. Knowing the signs of hypoglycemia. So I think we assume a lot of times people come to us with diabetes and they understand diabetes, but that's often not the case. So providing them with some information about the basics is quite good. And I would say the hypoglycemia handout should probably also be handed out much sooner. Hindsight, probably should put that in the first document as well. But this is a link to the Diabetes Canada hypoglycemia handout that explains the signs and symptoms of low blood sugars. They should always recommend that they should always carry fast-acting sugar, again, Dextabs or Rockets, in case they're out and have a low, and speaking to the PD team if they're having trouble managing, or their HD team, nephrologist, whoever they can talk to, have access to, and will listen, about making some alterations if need be. So those are the 3 documents. Those are a stand-in until we can do better, to be pretty blunt about it. Those are great documents, but they are documents that are very possibly going to get put in a pile with all the other handouts we give them and need to be reviewed more frequently. So it's only as good as we make it. So if we're putting it into play, and we should make sure we remind people and go over it again. But ultimately, I still go back to, we really need diabetes education in renal programs. I was fortunate enough to go shadow the diabetes renal RN in Calgary. It's the only one that we're aware of in the country. And it was fantastic. She saw PD, HD, and home hemo patients at that time. Their program was quite a bit bigger than ours in Abbotsford, but it was it was fantastic. So she saw patients at very different intervals. So the ones that we've just discussed, she would also see people if they were discharged from hospital, because that's a big transition in blood sugars and diabetes or dialysis management. There was a whole criteria there, but it was pretty impressive. There was the amount of things that she could manage there. I think having a diabetes renal educator would delay, especially if you work within KCC, you can delay the need for dialysis, because when I tallied it up, 50% of our PD patients here in Abbotsford have diabetes, and I think it was the national from the Kidney Foundation, it's like 42%. Like, there's a high amount of patients on dialysis who have diabetes. So we really need to focus on managing that to prevent it from turning into end-stage kidney disease. So I think if you had more focus on that, especially in kidney care, you could delay need for dialysis, increase suitability for home modality like PD. So not having to turn people away whose blood sugars are out of control, like knowing that PD is not going to maybe work for them. If we could improve that and make them more suitable, that'd be fantastic. We could improve UF, maintain or increase suitability for transplant, prevent or delay diabetic complications such as vision loss, amputation, gastroparesis, all of which impact their ability to do their dialysis or how well it functions. The other part would be having a diabetic nephropathy prevention clinic, similar to the one that Edmonton has. So it's outside of a kidney care clinic. It is focused on patients with kidney disease and diabetes, and their focus is to prevent them from needing dialysis or delaying diabetic nephropathy. So yeah, that would be my recommendations beyond this, but a stand-in for now is these 3 documents. Any questions?
Yeah, thank you for that. There's a link, a question in the chat, if you could share the links for the handouts, and maybe that's something we could do through the PD committee.
Yeah.
That'd be a good idea. I guess my question while I'm waiting for others is, there seems to be a lot of emphasis on written material, and many patients don't read, and it's also all in English. And I'm just wondering if you've considered like videos or little podcasts or something, and translation, and maybe that's something that could be done at a provincial level, because there are languages that people speak, not just English. So have you thought about that?
That was brought up at the PD group that I presented to as well, and having a video of it, because we had also looked this year. I had originally got funding but ran out of time, was for creating a course for PD nurses or PD staff, but realizing that maybe not hitting the mark. But one of the suggestions was exactly that, creating a video so that it's out there for, that was specifically for staff. But yeah, I think that would be a really great addition for patients as well. And in terms of language, the way we got these written up through our professional practice team is we got it to a level where we could in future look at translating these documents to other languages as well.
Great. Other questions that people have? Or comments, or what people are doing in their units? I know that there are a number of integrated diabetes, like within the KCC. There's one at St. Paul's. We have a integrated clinic with a diabetologist and a bit of uptraining of the nurses in the KCC group. I don't know if someone from St. Paul's wants to comment on that and transitions to PD and if there's any overlap. Or not. Hold on,
I know Royal Columbian, they do have their diabetes educator is an inpatient diabetes educator, but part of her role is also seeing PD patients. But again, that still leaves the big gap of what about HD? What about KCC? What about transplant? So you've got a big gap being missed there, and she's not within the program. She's referred to case by case. So if someone's a new start or if they're having specific issues, then she could be pulled in. But it's a good start, but it's only one hospital and not enough access for everyone.
Yeah, I think it's certainly, you've highlighted, a very not well known, but it's been staring us in the face for a long time. Like, as you said, 50% of the people have diabetes. So our ability to do wraparound care is limited and variable across the province, and yet it's a big need. So I think it'd be nice to sort of figure out how to make it more integrated.
Yeah, I agree.
Yeah, is there another question? Oh, someone's typing an answer. Okay. Other questions that people have or comments that people want to make? Doesn't look like it. I think there's just somebody wanting the links, and I think that we'll figure out how to get them to them.
Yeah, trying to share in the chat, but it looks like I'm only sharing with the host and panelists.
Right. So I think, I think what we can do is if people are interested in seeing your handouts and working with you, then if you don't mind, we can connect you. Is that all right?
Absolutely, yeah. Or I can send them to you guys if you want to fan them out to whoever.
Yeah, that'd be great.
Yeah, the more people have them, the better.
Yeah.
And in Fraser, it goes to our print shop, so we're going to get printed color copies for our end. But I don't think outside of Fraser, people are going to have that option. But you'll be able to print your own.
Right. Oh, it's been put into the it was put into the chat with the link, so that's great.
Beautiful, thank you.
Yeah. So I want to thank. Oh, now there's a bunch of questions. Let me just no. Everyone's just thanking you for the excellent work that you're doing, and I was just going to do the same and give everybody 10 minutes back in their day. But I very much want to thank you, Monique, and Scott. I think there are lots of excellent work going on within each of the programs, and then also on ideally with dissemination to the rest and integration with the provincial committees. So it's really great to share it in this kind of a venue so that everybody knows what's going on, and the progress that you're making. We're doing this with all of the health authorities to showcase the various innovations. So I want to thank you both for the work you do and the teams that you lead and the patients that you're impacting by that work. So thanks again, and happy Friday, everybody.
Thanks.
Thanks for having us.
Okay.